All right. So I guess I will go ahead and get started then. And so this lecture, I prepared for clergy of the Wichita Diocese, and just trying to target some things that I felt like our local clergy should know about coronavirus and about kind of the state of how things are, as well as how to protect themselves. So this is definitely a moving target as we're learning more about the virus and about how to protect ourselves. But I felt like this was just a very kind of timely lecture, particularly for our diocese, since we're starting to see cases popping up, and just wanted to make sure our clergy were fully aware of the situation. So kind of why I'm giving this talk also is I just kept seeing headlines come up of clergy that have died administering to patients that have had coronavirus, particularly in Italy, some in Spain, some in other parts of the world. And I just wanted to make sure that as much as is possible, as much as is reasonable, that clergy are aware of how to protect themselves and how to protect others, so that we hopefully don't see similar headlines here in the US. Um, and maybe I'll just say a few more words about myself. So I'm a family physician, but have a particular interest in infectious disease. I did some extra training in tropical medicine. I've worked in Africa for almost a year. I volunteered with the Ebola outbreak. So personal protective equipment, as we call it, is very much part of my training, and my, I appreciate it so much, having worked in that environment in Africa. And so because of that experience as well, I felt like this was just something that was really kind of near and dear to my heart, to make sure that that we are protecting our clergy and those in our diocese. I have a couple of people that have just joined, Father Joe and Cheryl. I've actually just gotten started. So if you would go ahead and mute, and then this is kind of my first slide here of why I am doing this talk here. So thanks for being with us. Dr. Cheryl Beard is also on this talk, and then she may jump in with some other ideas. And Father Joe Tatro is also on this lecture, and then it will be saved and recorded for the clergy of the Wichita Diocese. We're kind of starting off sort of with some of the basics. I think everyone probably knows this, but I just thought I would just kind of run it back a little bit, just to make sure everyone's on the same page as to what is a virus, how is it different than a bacteria. A virus is not technically alive. It is just basically genetic code that has a protective coat around it. It doesn't move, it doesn't reproduce, it doesn't have any internal activity within it. It's not a cell like a bacteria is. But the way that it works is that it hijacks our own cells, and it makes more of itself. And during this process, it causes inflammation to those, and often will kill those cells, or your immune system will recognize that this cell has been infected with a virus, and it will attack those human cells to try to stop that process of reproduction. And depending on where this is in the body, this will have different effects and different symptoms for the person that's experiencing that. It's important to recognize that antibiotics don't work for viruses. They work for bacterial infections. We do have antivirals, which work against viruses, but none for this particular virus yet. And there are also vaccines that work against both bacteria and viruses, but we don't have any for this particular disease yet. There are some similar diseases to the current one that we have, to COVID, but that vaccine process never fully went through. And so right now we're in a stage where we really don't have a lot of treatment options. And so protection and avoiding the virus is really our best bet in terms of keeping ourselves and our society and our community safe. So just some basic facts about what we're calling COVID-19. So that's the coronavirus disease that started in 2019. That's the disease. There's also the virus, which has been called SARS coronavirus, SARS-CoV-2. So it's the second one. It's very similar to the original SARS virus, which was back about 20 years ago. And so genetically it's very similar. So that's why they named it that. But for the purpose of this lecture, I'm primarily going to be calling it COVID-19, or occasionally I'll call it coronavirus. But it's important to know that there are 4 normal coronaviruses that are out there. These cause the common cold, sometimes upper respiratory symptoms, sometimes mild bronchitis, but these are always circulating, and they're typically highest December through April. And so there's a seasonal pattern. However, they are throughout the entire year. So sometimes you'll see on labels of Lysol or other packaging, active against coronavirus. And yes, it's active against this coronavirus, but it's also active against all of the other coronaviruses that are out there that affect humans. However, this one is new to humans. It's been in animals, but it's brand new to the human species. So we don't have any immunity to COVID-19 or to the SARS-CoV-2 virus. We don't have any vaccine or treatments yet, as we talked about, and we actually don't know if it will be seasonal. There's several other coronaviruses that that have infected humans as very short outbreaks. One was called SARS, and one was called MERS. And for MERS, that one was not seasonal. And for SARS, they were actually able to stop it before the seasons changed. So we don't know if that one would have been seasonal or not. We're hoping that this one is seasonal and that we will get relief, starting around May as the seasons change. We are hoping for that, but we really don't know if that's going to be the case. The incubation period is the time between the time you were exposed to a virus and it got into you and the time that you start having your symptoms. So you might be exposed on day 1, but you might not have symptoms until day 5. But the total incubation period, the total possible time period that it could still be in you, but you haven't yet started to have symptoms, would be 14 days. On average, most people start to have symptoms around day 5 or 6 after they've been exposed to somebody with it and it's gotten into them. It takes a little bit of time for the symptoms to sort of ramp up. Usually most people recover in a couple of weeks, but it is possible that the virus could still be shedding for even as long as a month as they've tested people. Most people probably won't shed the virus for that long, but that means that they could potentially still be able to spread it to other people for that entire time. Of the people that have been tested and tested positive, the majority have mild or moderate cases, meaning that they might feel miserable, they might have severe flu symptoms, they might have mild symptoms, they might have no symptoms. But of the people that we have tested, the majority, about 80%, are not going to need hospital care. They are going to recover on their own. They may need extra rest and extra fluids and medications to kind of help them with their fever. They're going to do okay. About 20%, as far as those we have tested, appear to have severe or critical symptoms where they would need to be in a hospital receiving oxygen or even a ventilator. They're going to need a lot of support that would require a healthcare system to intervene. So that kind of is the breakdown that we're seeing right now. It's been pretty true throughout multiple countries. And so we're thinking that might continue to be the case here in the U.S. As we continue to test. There's in the last several weeks, there's come up with a lot more information about asymptomatic cases, people that have the infection that test positive if they do a swab, but they don't have any symptoms. They don't have a cough, they don't have cold symptoms, and this may be as high even as 20% of people. Particularly in children, they seem to have no symptoms or very, very mild symptoms, but they could potentially be infecting others. We also have seen from some studies that maybe between 10 and 20% of new infections occur from people that just haven't started symptoms yet. So they're not asymptomatic, meaning that they don't go through the whole course of the disease without having any cough or cold or fever. They do develop those things, but maybe 24 or 48 hours later after you've been around that person. So we're still, I'm not doing anything, but they are still researching this as to see how much of this is really the case. And so more studies need to be shown to see, is it really being spread by this pre-symptomatic people, meaning that say that I feel well, but maybe I sneeze accidentally because of allergies and potentially could infect somebody else if I'm within that 24 to 48 hours before I actually start coming down with my flu-like symptoms. So more is needed, but I think that we can be cautious just to recognize that there may be some people that are spreading it without necessarily having a lot of symptoms or maybe just having very mild symptoms. The bottom line of all that is, while it's unlikely, Others could maybe spread it to you before they have symptoms, and you could maybe spread it to other people before you have symptoms. And I think that's very important for clergy to recognize. We don't know how often this is happening, but some studies are concerning, saying that maybe this is happening more than we would like to believe that it's happening. So be aware of that as you're approaching interacting with people, that this could be something that ends up being problematic. Where did this come from? So originally the coronavirus was in bats, and we think that it probably came from a pangolin, which is this little creature that I have on the side here. It's used for Chinese medicine. There is an apparent link to this seafood or exotic wet market, animal market, so there's, most cases seem to link back to this. There's other possible theories that there is a biohazard lab that's there in Wuhan, and they think maybe some of those animals were sold for human consumption or for other purposes. Maybe that's where it spread. Probably not something that we'll know until a long time from now, if we'll ever really know kind of where, what was the intermediate host of this virus. We do know that it originated out of Wuhan, China. So in terms of the mortality rate, this comes up a lot, and it's debated very heavily, and we don't really know for sure what the ultimate case fatality rate or the ultimate mortality rate is going to be for this disease, because we just don't know how many asymptomatic or mild cases are out there. We don't know how many people had it and recovered, maybe with hardly any symptoms or maybe no symptoms at all. And until we have the ability to just test in a huge way, we really won't know that. The other way we might be able to know how many people have had it and recovered, maybe with no symptoms or very few symptoms, would be to test their antibodies. And I think that some of those tests have just gotten approved through the FDA. We're really not doing that. So we really don't know what our denominator is. When you look at the fatality rate, you need to know how many people are dying on the top. Then you need to know how many people total had it. And we just don't know that yet. What we do know is that of the people around the world who have tested for this, who have been apparently sick enough to test for it, or happened to be on a cruise ship and everyone got tested, or however they ended up getting tested, of those who are testing positive, the case fatality rate is somewhere between about 1 and about 3.5%, meaning that of those who are testing and are testing positive, about 1 in 100, about 3 to 100 will die from this. The case fatality rate will probably be higher, as we've seen in Italy when healthcare systems are overwhelmed. I think France and Spain and China and Iran are other examples of where healthcare systems are struggling to keep up with this huge number of new people coming in. It's also higher in populations that are older to begin with, because they're at a much higher risk of dying of this. So those are some things that can change that case fatality rate. We do know that for seasonal influenza, the case fatality rate is about 0.1%, meaning about 1 in 1,000 people who get influenza will die from that or from sequela of having influenza. So there does seem to be a pretty big difference there, and I think that's important to recognize that this, as far as we can test and as far as we know, does seem to be quite a bit more fatal than seasonal influenza is. So what's the big deal about it? As we talked about, it's potentially 10 times more fatal than influenza. Again, we don't really have that solid denominator number yet, but it certainly does seem to be a bigger deal. Other things about it, though, it's spreading at least twice, maybe 3 times as fast as influenza. Probably some of that's due to the fact that we have a little bit of immunity to influenza if we've fought it off multiple times in the past and we've gotten our vaccines, and it may not be quite the same strain, but we're going to have a little bit of immunity to that because of the number of people that have had it in the past. So it doesn't quite spread as much when people have some, what we call herd immunity. There's some immunity in the population towards it. We don't have any immunity to this one. Just because you've had one of those normal coronaviruses, it actually doesn't help you at all in this situation. But the biggest deal, I think, at least for me as a healthcare provider, is it has a much higher hospitalization rate than influenza. And these patients that need hospitalization tend to be quite sick, and they need oxygen, they need ventilator support. So because of how quickly it's rising and spreading, and because of how many people need hospitalization, it does have the capacity, the potential capacity to overwhelm healthcare systems very quickly. Compounded to that, we don't have enough tests to really test people in a lot of places. That's been, I think, on the news plenty that you all know about. We don't have enough personal protective equipment for nurses and doctors and other healthcare workers. So that's also a concern. We may not have, we don't know, but we may not have enough hospital beds and oxygen and ventilators. And, so it's possible that some people also wouldn't benefit from a ventilator because of their underlying medical conditions, and they may choose to go home with palliative care instead of being admitted to a hospital where they might not be able to have visitors, or they might say that's just really not something that I believe is going to be beneficial for me. So we talk about that burden and benefit within the ethical and religious directives. So there may be people that are going to be at home in the last days of life. I think everyone is a little bit familiar with also the concept of flattening the curve, which is what multiple states are working on right now, trying to reduce this potential rapid rise of new cases over and above what our healthcare system can handle. Even if we have the same number of people infected, but it's over a much longer period of time, it allows us to have time for planning, time to get enough personal protective equipment. We've got to get factories up and going. We need to get factories to produce ventilators and potentially get some more oxygen, to set up hospitals, kind of reconverting them into almost more military style situations. So we've got a lot of things that need to happen that we just really need a little bit more time for. And so I don't want to get into the debate between the challenges of the economic downturn and the, what do you weigh and kind of who do you pick and what do you value. I don't really want to get into that because I think that that's above and beyond my scope. But I do think that any bit of time that we can sort of buy the healthcare system to allow them to ramp up their own systems and production will be tremendously helpful for everybody. Even if you don't get COVID, or even if your loved one doesn't get this, if you need to be seen in the healthcare system for any other reason, it would be a lot more challenging if the healthcare system is overwhelmed. So I pulled this off of a website that goes through state by state for kind of the worst case predictions of what they are looking at. Every prediction graph and value is only as good as its the numbers that you plug in. So that is obviously up for debate, but the dotted line at the bottom is the healthcare system capacity on this particular model. And if we don't do anything, it shows the potential, hospital overload situation. And then if we do some of these measures, we may still be over our hospital capacity, but not nearly as much. And it'll be spread out over enough time. We might be able to get enough. We might be able to set up hospitals in hotels and other things that we might need to do, but we would have more time to sort of prepare for that and to get ready. But if we, regardless, I think there's going to be a huge need for, particularly for clergy, to be supporting all of these people that may, again, we don't know the future, but they may end up needing support outside of the healthcare system because there may not be a lot of capacity within the healthcare system to care for everyone that needs it. So my hope is that this is not the case. I know that the hospitals here in Kansas have been working very diligently to hopefully avoid this situation. We're also a rural state, which for the most part, which changes things. It makes it, things spread more slowly in rural areas, and that may be very much beneficial compared to a city like New York or Los Angeles, where people are much more tightly packed. But I just put this out there just to say that there is concerns even in Kansas that we might end up being in a situation, kind of a crisis situation, where we're particularly will be relying on clergy in the outpatient and the outside of the healthcare setting to really help minister to people in a place where there may not be capacity within the healthcare system to provide that. So let's talk a little bit more about COVID-19 and kind of what it does and how it works. It's a virus. It attaches to receptors in cells in your lungs, and then it invades those cells, and then those cells start churning out more virus. It can attach to other places as well, in the throat and the nose and the tongue and the intestines. Primarily, it for most people causes cough, fever, pneumonia, difficulty breathing. It can cause a sore throat, some diarrhea, some nausea, abdominal pain. There's other things that can come with this as well. And so it's important to recognize that, just because someone doesn't have a cough, fever, or pneumonia doesn't necessarily mean, if they've got a sore throat, diarrhea, nausea, and abdominal pain, they might be kind of heading towards, the path of COVID. You just need to be very mindful of that if you're clergy. Severe cases can develop into lung and heart failure, and as well as other organ failure. And that's more particularly important for people that are older or they have other health conditions. However, young people are still ending up in the ICU in the hospitals, and still have a risk of death as well. So it largely spares the young. It's sparing children largely. It seems to spare pregnant women and newborns. But that's not to say that the risk is nil. There is some risk there as well. It's spread, as I think everyone knows now, by respiratory droplets. So primarily, talking or sneezing, blowing your nose, but potentially also by laughing, talking, singing, anything. If you've ever seen somebody give a speech from the side with the lights on the other side, you often will see these droplets coming out of their mouth if they're really getting into their speech. So we know that droplets are occurring all the time. So these droplets, with gravity, do tend to fall within 6 feet of a person. You've got your large droplets within 3 feet and your medium droplets within the 6 feet. There's debate as to whether this could have small droplets spread. If so, it's probably pretty unlikely. But we do think that 6 feet is sufficient for separation. I think there's more research in that, but I feel pretty comfortable with that number, that those droplets are going to fall within that. The second way that it's spreading is it's on your hands, and then you brush your face, your mucous membrane. So that's your eyes, your nose, your mouth, and that it will enter in that way. So that's a second thing to be aware of, that's probably more common than even the respiratory droplet, is that somebody will cough and sneeze. Some of those droplets land on a surface. You touch that surface, or you shake their hand, or somehow touch them or touch something else, a handle, a door handle, a gas pump, something else, and then you rub your eyes, or you rub your nose, or you rub your mouth. So that may be maybe the most common way that we think this is being spread. It seems to be able to survive on particular metals for up to 3 days, on cardboard for about a day. It's possibly spread through the fecal-oral route, which a lot of viruses are, and we do know that the virus is in the stool, and we do know that diarrhea is not uncommon, particularly for children. I think it's even more common. So it's possible that it's being spread this way. People aren't washing their hands well enough, or if children are having diarrhea, that's always hard to keep clean. So that's just something to be aware of. But it hasn't been shown yet in any studies. I don't know how well they've looked for it, but just something to keep in the back of your mind. We do think that it can spread, in an airborne route if or through aerosols, if they're on a ventilator, if they've just had a nebulizer treatment, which is often for asthma or for COPD, for wheezing. Sometimes with very high flow oxygen, maybe it could be spread through the airborne route, because you've got a lot of pressure with this blowing oxygen. And so those would be some situations that would make you want to use even more care and more protection. So the first symptoms are not actually generally fever, cough, and shortness of breath. The first symptoms for the first day or so are like every other virus, right? You've got your malaise, your fatigue, your muscle aches, maybe some nausea, abdominal pain, maybe some diarrhea, scratchy or sore throat, decreased appetite. An interesting one is this loss of smell that is being recorded very, very often. Some people have a loss of taste, but primarily it's this loss of smell that people are reporting. Even people that have no other symptoms at all of the virus are still reporting this loss of smell. It seems to come back, but I think that's something just to kind of keep in the back of your mind. That's an interesting one that we're just now discovering. And then within, some period of time, it could be a short period of time, or it could be over the course of a couple of days, patients will start having a fever, a cough. It's usually a dry cough, and shortness of breath. And then that can develop into lung failure, where the oxygenation of the lungs doesn't work anymore. And those lungs start to fill up with little bits of fluid where that oxygenation should be taking place. And so we call that acute respiratory distress syndrome. And these patients, a lot of these patients they'll certainly need high flow oxygen, and a lot of them will need a ventilator support, potentially as long as a couple of weeks. Most people are on a ventilator if they're on it for about 10 days. So it's a long time that they're needing a ventilator for, and that's kind of the average. So the hospitalization after you start having symptoms is around 6 to 9 days. And if patients are going to die, it usually is in that second to fourth week. It can be earlier, and so I think that's important for clergy to know, but it is often later. And the last thing I think is important for clergy to know is that just with ARDS in general, about half of people that end up on a ventilator because of ARDS for any reason will die, and we're seeing rates in the 70s or 80% so far of patients who end up on a ventilator that end up passing away. And so that is something we need to just continue to work on. But even in the best of situations outside of COVID, ARDS is a very severe condition and can have a high mortality rate. Some patients will have organ failure or heart failure right at the end, and so it can go very, very quickly. So while most patients, it's kind of a slower process over several weeks, some people, it can be a very quick process between the time that they start having symptoms and the time that they pass away. Some people, it's even within the course of a week that they can go downhill pretty quickly, and other people, it can take several weeks. We do have some testing for this. It's been difficult to get the testing on board, but there's a swab that goes in the back of the nose or sometimes in the back of the throat. Right now in Kansas, I think we're doing the back of the throat now, but initially we were doing both nose and throat, and that will probably continue to change as things go along. The test results can take time to get back. Several days, would not be uncommon. And the test results are not 100%. So there seems to be a fairly high false negative rate. So meaning that the patients still have it, they actually have the disease, they actually have the virus, but that swab didn't pick it up, or the test wasn't able to pick it up. So about 30% of people that test negative actually really do have it. And they would need a repeat test to find that, or they might have a CT of their chest and discover it that way. So that's something that hopefully they'll have better tests coming out soon. And we don't have antibody testing. Hopefully we'll have that soon. And then we can tell more, if clergy think that they've had it and gotten better but never got tested, we might be able to know if they're immune or not in the future. And so that would be something that would be very important for clergy to know. Well, have I already had this disease? Am I at less risk of infecting other people because I've already had it? We just don't have those tests yet, and hopefully we will at some point. We don't have any treatments, as we talked about, yet. We don't have a vaccine yet. There's lots being tested. There's lots that's coming out, but we're not quite there yet. But what we do is supportive care, which involves, medication for fever, maybe some fluids. Some people actually have too much fluid. We have to pull it off. Some people need electrolytes supported, blood pressure support. Oxygen is a big one. And then some people will need ventilators as well. So in terms of whether people are being reinfected, we really don't think so. I know this keeps coming up in the news, but because the test is so imprecise, it's possible that the person continues to have it, and they might have a couple of negative tests, but it might just be that the virus wasn't on that. And we know that people still shed the virus for up to a month. So I don't think that people are being reinfected, but we really need those antibody tests, and we can do a lot more with that. For now, as with most viruses, you at least maintain immunity for a while. So if you have antibodies, you've had the disease, you've gotten better, I would not be concerned about these reports of reinfection, because I don't think that they're real. So another thing that's come up is, why are some hospitals limiting visitors and clergy? There's several reasons for this. Primarily, well, primarily it's because there's not enough personal protective equipment, even for hospital staff. They're working on that. They've got um, companies locally and internationally and nationally that are starting to make masks. That is coming on board in the next week. It is really ramping up, so we're very happy for that. But that has been one of the reasons I think some hospitals have limited this, because they don't have the spare masks and gowns and gloves to go to other people, including visitors, including clergy. The second important reason is that they want to limit the chances of somebody accidentally bringing it into the hospital or somebody accidentally bringing it out of the hospital. So there's a risk both ways. So if visitors come in and they don't know how to wear the personal protective equipment, and then they either bring it in with them unknowingly, or they take it out with them, that's a real problem, because that's just going to continue to, circulate the disease in a way that we really want this to shut down. That either way, it's a bad deal. I do think hospital policies will continue to change over time. They're not stagnant. A lot of it is dependent on personnel and how many cases you have and PPE and all of that sort of thing. So volunteering in the hospital is very noble, but I just want to repeat again, this clergy will be desperately needed, I think, outside of the hospital setting. And I say outpatient because that's the term that we use, but outside of a healthcare setting, we will really need clergy to be ministering to people, because I think that's going to be a huge need potentially. So again, I don't want to paint an overly dismal picture, but I just want to make sure that if we're ever in a situation like Italy, that we don't have headlines of people throwing themselves into situations very nobly, but without kind of that understanding of the risks to themselves and to others. Sorry, Father Joe, did you have something to mention? Okay, all right. So in a couple of comments here, quarantine and isolation. Most people use the term isolation to mean both, and that's fine if you want to do that. But there are differences in terms of what they mean, at least by healthcare standards. And I think you just need to be aware of that. Quarantine is for well people that have no symptoms. They might have been exposed to somebody. Maybe somebody's sick in their home, and anyways, they are quarantined. They're waiting to see if they're going to develop symptoms. Maybe they're waiting for a test result, but they're not actually sick. And so that is 14 days because of that incubation period. So when I came back from Liberia after working with Ebola, I went on quarantine, but it was 21 days. And so I had to stay, in one place, not interact with other people, take my temperature twice a day, prove to the Texas Public Health Department that I was not sick. And then after those 21 days, I could go and do whatever I wanted to. It's different than isolation. Isolation is for sick people who test positive, or maybe if tests aren't available, they seem to probably have this. And a sick person ideally will have his or her own room, ideally their own bathroom. Hopefully they can have a mask. Family members should wear masks if they're getting close to that sick person, just to protect themselves. And right now, the CDC guidelines, as far as I understand them, allow someone to leave isolation after they've been sick if it's been both 3 days since their last symptoms without medication. So it's not like you can lower your fever and get by, but 3 days after your symptoms. And if it's been 7 days since the start of your symptoms, that's when you can leave that isolation period. And so that hopefully none of our clergy will be in that situation, but that is those are the guidelines for sick people who have symptoms and seem to be sick or test positive for this. Now it's possible in the same house to have someone who's on isolation because they've tested positive, and family members who are caring for them who are going to be quarantined. And the question that I have that I don't know what the right answer is from the CDC is, does the well people have to stay in quarantine 14 days after the last day of symptoms of the sick person in their house? And I really don't know the answer to that. And I hope that there will be some clarity to that. Dr. Beer, do you happen to know what the right answer is to that question?
I actually was going to ask you a similar question. So Yeah, I don't know the right answer to that. And I also had questions just about it being prolonged. You know, if you can shut it up to a month, then, you know, that's another question I had.
Yeah, and I think people are asking those questions to the CDC. I I don't understand these guidelines by the CDC because they don't seem to fit with what we know currently about the disease. And that concerns me that people are going to leave isolation and still potentially have the virus, or they won't be sick, but they might still be shedding that virus for a little bit longer than that time period. So so those are several questions, and those might affect clergy that are living in a community situation. If one of the clergy ends up going on isolation, then the other clergy that are or seminarians that are caring for that person. I'm not quite sure what the situation here is locally with our seminarians, but I really just don't know how long the seminarians caring for the isolated priest would need to be in quarantine after that. I would err on the side of safety and say try for a prolonged quarantine, saying that you should quarantine for 14 days after the last day of symptoms at least. But man, this is a tough one, and I'm hoping that we'll have some more scientific data to say, just because a person's shedding virus, does that mean that they could infect others, or does that just mean that they might just have some inactive virus that they're shedding? And I just don't think that we know that. So I think that a question that a lot of us, that we want to throw ourselves in and we want to help others is, why should I worry about myself? Like, I've, given my life for Christ, and, healthcare workers could say the same thing. Like, we, why would we not just sacrifice ourselves because maybe we're young and healthy and we don't think that we're going to have severe symptoms, or maybe we just want to value the other people more than ourselves. But I just wanted to remind people of like what every airline recommends. Is that if you're in a bad situation, you need to put the oxygen mask on yourself first before you help other people, because that's what's safe. And even when I was working with the Ebola treatment unit, even if a patient was really sick and needed our urgent help, we still had to do the 20-minute prepping to put everything on, to tape it down, to have somebody cross-check, double-check before we could go in and care for those people, even if they were very, very sick. And the reason is, if we got sick, then there was more people sick, more people that we might infect accidentally, fewer healthcare workers, or in your case, fewer clergy. So I would just, that's kind of why I think it's just really important to frame this as these measures that I'm going to recommend are to help reduce your risk as clergy if you end up in a situation where you are ministering to people who happen to have this virus, or even just have other diseases, and you don't necessarily want to spread your germs to somebody who is who might be homebound and sick with something else. So that's what this is kind of going to be going forward. So first of all, how can you keep yourself safe? Again, it's really important, I think, that you frame it in the sense of charity. Like, keeping yourself healthy and well means you're not going to give it to other people. It also means you're going to be able to continue to minister. So hand washing, really believe in that. It gets the germs off your hands. Hopefully I can click on this and it will pop up. I just really liked this little video, and sorry for all of the extra stuff on here. There's no sound. But hopefully you can see it. So it just shows how to hand wash. And I think we, even in healthcare, like, we don't do it very well sometimes. Like, we do this before we go into the OR, into the operating room. But you can see, so you're doing the front and the back, and then you do the fingers that way. And then you don't want to forget about your thumbs. So you kind of go around there, and then you do the other thumb, and then you've still got some white on your gloves. And so you want to get your fingernails there, and then you've still, kind of want to make sure that you get the rest of it, and then now you're done. So that kind of does that. So I'm actually going to show that again, just so that you can make sure that you watch that thoroughly. So palms of the hands, between the fingers, backs of the hands, between the fingers. There's still some areas there that didn't get thoroughly done, so you want to rub your fingers that way. You want to do your thumbs. You want to do your other thumb. You want to get the tips of your fingers because underneath your fingernails. And then finally, you want to do your wrists. So this should take about 20 seconds to do every time. That is how to do a proper hand wash. Let me see if I can go back into, there we go. So practice that. I think that it's important to practice that. I think that we all just need to remember to take the time to actually do it. And it's the same if you are hand washing with soap and water, or if you are doing it with gel. Get into your routine and make sure that you're doing it the same way. You're not missing areas of your hands where germs can sit. We need to all of us stop touching our face. We touch our face about 16 times an hour, maybe more. The T-zone is our source of infection. So those are your eyes, nose, and mouth. And anything that's on your hands, when you touch your face, it's just going to get right in there. I do think that the 6 feet distance is sufficient to avoid droplets from breathing, talking, laughing, sneezing, all the things that we do. So, as much as possible, try to maintain that 6 feet distance. As hard as that is, as uncomfortable as that is, try to keep doing that. Obviously, stay home if you're sick. Please stay home if you're sick. We all need to stay home if we're sick, especially right now. And then if you're in a shared living space, be really intentional about cleaning the high touch areas often. You can Lysol them, you can wipe them down with Clorox, you can make your own, bleach solution. There's still plenty of bleach, I think, out there for swimming pools. You just need a little bit, you just put a little bit, and you can find them on the internet of how you would make your own solution. But, think about light switches, door handles, knobs, cars, car handles, steering wheel, all of the places that might be high touch or might be common places, counters, dishes, if you can dishwash them, that's probably higher heat, more soap. So just kind of think through, what are the areas in my living situation or my work situation that are shared and that might have that contamination. And this is one more thing on hand washing. There's one where you can say the Lord's Prayer and then say the Hail Mary, and that kind of gets you through it. So that way you're not skimping on your time and hopefully doing it in the right order. And so if you want for what that's worth. So what is personal protective equipment? It's items to keep you safe from being infected or potentially from infecting others. There's a lot of different types of equipment depending on how things are spread, but right now we're going to talk about masks, eye shields, gowns, and gloves. So donning is a term that we use in healthcare to put it on. It actually comes from the word do on. So you put it on, you do it on, and then you do it off, and that's doffing. And so that is taking it off. And this is true in Ebola, and this is true here. It's actually probably more important how you take it off than how you put it on. It is more likely that you're going to get infected through taking it off the wrong way than it is through putting it on the wrong way. So just be mindful of that as you're taking it off. This is what a healthcare worker would use if they were going into a patient area that was something that was spread through respiratory or droplets. So eye protection, she's wearing an eye shield, which is attached to the mask. She's wearing a surgical mask, which is fluid resistant, wearing a gown, and wearing gloves that cover over the gown. So should you even bother with this? So not if you're going to be 6 feet away from others at all times, but do consider you might step into a bathroom immediately after somebody leaves, or an elevator or a stairwell. Sometimes it's really hard not to have close contact. If there's children around, they're not going to understand this. They're going to run up to you. So there may be situations where you are not able to ensure that you're going to be 6 feet away from everyone, but there's some situations where you are, and you can maintain that reasonable distance. In which case, I don't know that it adds a lot to add personal protective equipment. If you're always going to be that far away, you're able to wash your hands if you touch anything. It's probably not needed, and that's what we're telling the general public. However, if you are going to be in close contact with someone, especially if they might be sick, I would recommend personal protective equipment. And what Kansas defines as close contact is more than 10 minutes within 6 feet. So that's kind of their guidelines to say, so what is close contact? So it is within 6 feet, but they say it needs to be at least 10 minutes that you're going to be in that situation. Again, my preference is to err on the side of caution. And so even if you're just going to be around somebody for 5 minutes, I still think it's probably prudent to at least consider, should I have personal protective equipment on? And my recommendation, given how many people you work with, would be yes, that anytime you're going to be within 6 feet, I think it'd be reasonable to have some sort of protective equipment on. So if you are in close contact with somebody who is sick particularly with COVID-19, and it's a sustained contact, that's when you would start your 14-day quarantine. So if you're a clergy and you are sitting with somebody who, the next day, and they're sick, but the next day they test positive, and you've been sitting with them for at least 10 minutes, and you were within that close contact, that would mean that, at least as of now, that you would need to start your 14-day quarantine, and that you would need to isolate, I hate to use the term isolation, but you would need to stay away from people who are well, just so that in case you develop symptoms, that you're not then exposing other people who then they have to start their quarantine. If we get a lot more cases, I would probably recommend, and this is not the CDC, this is not the Kansas Department of Health, this is Lisa Gilbert. I'm just, for what it's worth, if we get a whole lot more cases and it becomes very common in our community, I would probably recommend that you wear a mask for close contact with any person, just in case they are pre-symptomatic. So, that would be just something to be aware of, that could potentially be a protection if you're going to be in close contact with people. So what sort of mask should you wear? So surgical masks provide the best protection. I would say good luck in getting them if you can, if you happen to have some, definitely consider healthcare providers, because, we're still struggling to get ours, although I think some factories have come on board and are going to be supporting us locally now. But if you have them, they do provide probably the best protection as far as we can tell. Homemade cloth masks are probably better than nothing if they're used properly. So if you are using it incorrectly, and touching the outside and taking on and off all the time, then that actually probably increases your risk of getting sick, because you're not using it the way that a mask is supposed to be used. If you need some cloth masks, or you want some cloth masks, contact Linda Landau, and she is making some that have a space where you can put filters in, whether it's a vacuum bag or whether it's a coffee filter, and that would provide a little extra protection than just cloth alone. So we're trying to make sure that we have the best quality masks that would have a good filter for fluids and prevent you from actually getting sick. Really important thing, I can't stress it enough, everyone does masks wrong, but don't touch the outside of your mask once you put it on. Once you put it on, I recommend leave it on, and then when you take it off, wash your hands immediately. But try as much as you can to not be handling and touching and fidgeting with the outside of it, because that just gets germs, if there are any on the front of the mask from somebody else coughing on you, then you've got it all over your hands, then you're doing all of this, then you're going to rub your eyes. It completely defeats the purpose of the mask. So if you're going to use it, I would really recommend use it correctly, because you don't want to use it wrongly and then get infected. So again, whenever you're removing a mask, consider the front part of it where other people might have been coughing towards you, consider that to be contaminated if you've been in close contact with somebody. When you wash it, you want to wash it in hot soapy water. You want to dry it thoroughly before reusing it. If it has a filter, you'll want to throw that away. So we'll go through a little bit more about masks in a minute. Questions that we often get, both for healthcare providers, and I would guess that you would as well, is, do I need an N95 respirator? So this, some people call these masks, but they're actually really strong filters that filter out viruses and everything. Not necessary for the average encounter that you're going to have, even with a patient that has coronavirus. So the most recent study just came out of, I think, Singapore a few days ago, that said that they randomized, or I don't know how they did it, but they had a lot of healthcare providers taking care of people with COVID, even in the ICU, who had just surgical masks, and some that had N95s, and neither group got sick. So it tells me that I'm that is reassuring to me, that I do think that a surgical mask is going to be as helpful, at least in the general setting, as an N95. Now, we in healthcare, we use N95s if we're going to be putting a tube down someone's throat, because there's so much air movement and chance for infection. You're right up close to them, that's a real dangerous situation. And that's where we're recommending the disposable N95 masks that you've probably seen. So all that to say, I really don't think that this is something that clergy are going to need to be particularly concerned about. And I think that a surgical mask or equivalent is going to be just as good. But if you are a priest that is very concerned, or you're very high risk and you're just worried about it, if you happen to have, I have one N95 from my fit test, so that was when I got fit tested. You're welcome to use it. You need to make sure it actually works, though, and that it's actually filtering and you're not breathing around it and it fits your face. So there's, fit testing is necessary if you're going to use one of these disposable ones, making sure that it's really snug and that you're actually breathing through it and not around it. When you can reuse these, but again, you want to consider the outside has viruses stuck in it if it's doing its job. And so what we're doing in healthcare is if we're going to wear one of these to try to prolong the life of it, we're even putting a mask on top of the outside of it so that we can continue to use it several times. Now I hope that goes away soon. None of us feel comfortable with that, but that's what the CDC has said that we can do, just to try to prolong the life of these until factories can start making them. The virus is going to inactivate in several days. So you could put it in a paper bag and let it sit for 3 or 4 days. You could put it in direct sunlight for a couple of days. It does need to dry out. That's important. So if you're going to use a disposable one, you can't just use it day after day after day and expect it to keep working. And at some point, it's just not going to filter well anymore. And we really don't know when that is, because they're not supposed to be used multiple times. And we're just kind of in a learning stage right now as a country, is how long can we reuse these before they stop working? Another option, which some of you may have, is a mask like this that has it's more for like pollution, or if you're out mowing and things like that. But they do have a paper filter on the inside. They're probably better than nothing, and they probably work as good as a surgical mask. So you just kind of have to test yours and see. They are more comfortable. But again, if you're going to use something like this, the germs are going to be here, and they're going to be on the inside of this paper that's on the inside. So hopefully you can see that there's a paper that's in here that you insert and you take out and throw away. But you just need to think through, okay, the virus, if I'm breathing it in, is going to be here on the outside, or it's going to be here on this paper here. Now, again, these are for pollution. These are not medical standard. They are probably better than nothing. So just something to keep in mind. And the last option are these, and I actually happen to have one of these, but are these like scary looking Darth Vader masks that you put on, and then they've got filters that connect here and here of varying degrees, and that's also an option. It's I would say overkill, but if you are going to be seeing lots and lots and lots of people that all are positive with COVID, I think this would definitely protect you. It's going to be hard to clean on the outside because there's lots of crevices and things like that. So but I do know that some people happen to have these, or they have a half mask of it, and it works just fine. You just have to be really careful about when you take it off to know that the outside's going to have, if you're in close contact with people, if they've been coughing, it's going to be on the outside of that. And so that's something that, that you could consider. And again, a lot of people have them because they've done a lot of construction or mowing or whatever, and it works just fine. So these are just basically your 3 sets of options. You've got your surgical mask, you've got your N95s that are disposable, and then you've got these half face or full face respirators. And so those are your options there. I really do think that and I've got a cloth mask here somewhere. I really do think that a cloth mask, this one's made with a vacuum bag in it, and I think it works really, really well. It's just a matter of recognizing that that when you take it off, again, bacteria or well, not probably bacteria, but viruses, if anything has landed on there with the droplets, it's going to be on the front of the mask. Now, if you are sick, of course, it's going to be on the inside of the mask, right? So you just want to kind of think through that when you're using these. Should you wear goggles or any sort of eye protection? I would recommend it. It's just one other area of your face that can get droplets. So glasses are probably better than nothing. I don't think there's been a lot of studies on this. So, but goggles are probably the best because they really kind of protect your, your whole eyes. So that's one option. What I've seen one person do is wore a baseball cap and then had duct taped some plastic, just some thicker vinyl plastic, clear plastic that just sort of draped down. And I think that works fine too. There's face shields, but something to protect your eyes, I think would be helpful. Even if you're a swimmer, they've got those little swim goggles that would do the trick just fine. It's just a matter of making sure you remove it correctly. So should you wear gloves? I don't think so. If you are going to wash and sterilize your hands, there's nothing magic about gloves. And I think gloves give a false sense of security because you touch a lot more stuff and you might rub your eyes and it makes you feel invincible, but it really doesn't do anything. So I would recommend wash your hands correctly, bring some Purell with you, whenever you're, out ministering or even doing anything. I take it with me all the time now. And then just remember, don't dry your hands on your clothes. If you've been out somewhere, like use a paper towel or a clean towel that others haven't used. Otherwise, it kind of defeats the purpose. Should you wear a gown? Not necessarily. So droplets if droplets are going to land on your face, they're going to land on your clothes too, right? So if somebody's coughing, sneezing, and again, these are not droplets that you're going to see necessarily, but because they're small. But I think that if you wash your clothes as soon as you get home, you're going to be fine. So that's what I do with my scrubs. I obviously wear a gown if I'm in a patient that requires it, but even so, I just don't know. So if I still will come home and remove my scrubs and wash those immediately, or at least put them in the washer until I have enough of a load to wash them all together. So just no, I don't think that you need that, but I don't know if most of the clergy use dry cleaning as opposed to washing machines, but I would not recommend sending this off to a dry cleaner. I think that would put them at risk if they're even functioning right now. I'm not sure. So I would recommend whatever clothes you wear, they need to be clothes that can be that can be washed. Some people will wear a shirt or a poncho instead, sort of on the outside, and I'll show a video of the poncho. I thought it was really cool. But if you have a shirt that's kind of big, like extra large, for you, that with the buttons that would be on the back or something like that, I'm going to demonstrate here. Hopefully, I'm not sure that you will be able to see this, but like if I have this is my bathrobe or whatever, but you can put it on this way, and then when you take it off, have it up here, and then you can take it off this way. But again, I don't know how much that will do for you. It'll keep the front of you kind of safe, but if you end up sitting down with somebody to minister to them, then you need to think about where you're sitting, so that's still going to be uncovered. So just some things to consider there. So I'm going to show this video here, and then I'll show the other one down below. It's a little bit long. I'm going to go over an hour. But.
Lisa, do we need to be listening to the sound, or you think?
Oh, can you not hear it?
We can't hear it.
Oh no. Okay. Well, thank you for saying that. I turned it all the way up, and I can hear it on my end. I am not sure. What I will do is I will skip this and I will have everyone watch it with the link, um, so that you can all see how he takes it on, and he does his hands, he puts it on, and then just kind of watch how he takes off everything. And I think that that can be particularly helpful for everyone to watch. Now, again, this isn't a healthcare setting. It's going to be different for you in a home, but I think it's good to see how it's done in a healthcare setting, um, so that you're at least aware of what you're trying to mimic, in order to provide the best protection there. This one I don't think has a need for sound, so this one is a modification using a poncho, which I just thought was really cool, so that's part of the reason. Can you hear it? Okay. So he's turning the poncho around backwards so that the clear part goes over his face. He said he got these at Walmart, and then he's using this so that when he goes to test people, that he's got a full coverage there. So he's demonstrating the testing. And he says it's less risk of it going through. You want to grab it, and then he flips it inside out to try to keep it away from him, away from his clothes, and then throws that away. So that would be a possibility. That would be a possibility if you're just going to do kind of a one-off visit. If you're going to be doing a lot of visits with people, that's going to be a lot of ponchos to go through. But I thought that was really clever and a really good way of protecting eyes and nose and mouth, and clothes all in one go. So again, no desperate need for gloves, but you've got to clean your hands. And so when you enter the home of a patient, if so, let me stop and clarify. I don't know that this will ever be a need. I hope that it's not. However, it is possible that you may be going into homes at some point. Um, I will say at the end, kind of some recommendations to try to avoid that and try to provide, ministry outside of putting yourself at risk. But if you are ever in the situation where you know you're going to be entering a home with a patient who's confirmed positive, these are some steps that I would recommend. Again, just me personally recommending it, not any organization, not the diocese. I have not, I have not discussed with the bishop, so use obedience. But this is what I would recommend is, before you go into their home, you need to wash and sterilize your hands, maybe just outside the door, have your Purell or your whatever, and clean your hands really well. Put on your mask and your goggles. If you're going to use a shirt or a poncho, you can put that on, depending on the situation, how close you think you're going to be. Make sure you have everything that you need in your hands. I would not recommend sticking things in your pocket because you're just going to be dragging, potentially things in and out and in and out, and that could potentially have some risk. So I would give some guidance to the family members before you come, and tell them, you're wearing a mask because but you're not sick, so at least they're not paranoid, that thinking that you also have it, and that you're just taking precautions. Ask them to maintain a 6 feet distance if possible. Now, that may not always be possible, but depending on their home situation. But I would recommend you wash or sterilize your hands after you touch anything or anyone in the home, just because you just don't want to take the chance that you might accidentally rub your face. Don't ever adjust your mask, and I should put that on there, or your goggles while you're there, just because you're just going to have more chance to contaminate yourself. If you do, like, you just can't not adjust it or whatever, just clean your hands afterwards, and just be mindful. So this is not to scare people. This is not to like set down some procedure, but just to be really mindful about what you're doing, so that you're not potentially tracking germs around. Be aware, that your clothes could potentially have the virus if you sit down. Think about that. Try not to touch things that you don't need to. Try not to like rub your hands on your clothes if you don't, that could potentially spread it there as well. So when you're getting ready to leave, I would recommend, again, as you're leaving the house or before you leave, right after you leave, wash or clean your hands. If you have no other sick visits that day, remove your gown or shirt or poncho if you're wearing one, if you choose to wear one. Put it in a bag that can be washed or thrown away. Remove your goggles, and spray and wipe them down or clean them somehow, whatever you're going to do. If they're glasses, maybe clean them, and then put them away. And then remove your mask, and it depends whether you're going to reuse it or not. Depends what type of mask, how you're going to clean it, but you could put it in a bag, either to be thrown away or to be washed, but however you're going to do that. And I would recommend you clean your phone or anything that you brought with you, and then wash and sterilize your hands carefully after that, and then get into the car and go home. And when you get home, and this is what I do when I get home from work, so leave my shoes actually in the garage. I remove my scrubs, put them in a hamper, put them in the washer, try not to touch my face at any point. And then I clean anything that I may have used during the day, keys, pens, collar, badge, anything that I happen to have that I've touched. And then I shower immediately. And so what I recommend is, just in case you have anything kind of in this area, just like turn your face upwards into the water, close your eyes and your mouth and your nose, and just let it rinse over for just a second or two. It doesn't take much. I know this seems like a long procedure, but it doesn't take just for a few seconds, just to like get anything that might be around your face off of your face and then down into the shower and not into your eyes. If you wish to, if you're concerned about it, you can go back outside. I do this and clean my steering wheel, my car handle, and my steering drive and all that kind of stuff. So anything that I might have touched in my car, I'll just quickly go out and wipe it down, just to make sure I don't have anything there. So what happens if somebody in a home gives you something? I would recommend that you clean it, or you could let it sit out for a couple of days before you, like in your car or something, before you really handle it. So, I mean, there's a chance that there could be virus on there. Again, probably not that high, but it's still a chance. So that would be something you could just consider if they offer you something. And, if they're, I wouldn't recommend taking food from somebody's home if there's a sick person in their home, probably. I think you could microwave it or something like that. If you're going to heat it again, that would be fine. But just to be a little bit more mindful of that. If you have like a paper prayer book or Bible, it can survive at least on cardboard for 24 hours. So just be aware of that. I think screens are a little bit easier to clean. And so, you could consider using a screen instead of something with paper. You could just let it sit out for 24 hours as well. So what about the Sacrament of Holy Communion? So this is just kind of like a myth about how the silver or gold of the chalice prevents viruses and bacteria. I have looked and I cannot find a single study that shows that. There was something from back in the 1800s that actually showed that it does live on these surfaces. I know that colloid silver is theoretically supposed to prevent infections, but it didn't say anything about viruses. So I don't know where this myth comes from. If anyone has a study that shows that, I would love to see it. Lots of anecdotal saying like, oh, it doesn't do that, but no one can show me a study where that's been studied. So take that for what it's worth. We do know that this coronavirus lives for a couple of days on plastic and 3 days on steel and some other types of metals. So I don't know if gold or silver are different, but I would be very cautious about that. Everyone also says wine kills it, but we know that you need a high alcohol content. So probably vodka would, but I don't know that you're mixing your communion wine with anything stronger. So I don't think it would be strong enough to kill coronavirus, but I don't know that. It would at least need to be in that environment for a period of time. Now, wine is acidic, which is a little bit different. So maybe the acidity would inactivate the virus. But we also know bacteria and viruses are different in their properties. So what's true for bacteria may not be true for viruses. And so I think that you should just be mindful of that. I think personally that the virus could potentially survive on hosts for a day. Based on the studies from cardboard, it's probably a similar environment, but I obviously no one studied that. I think dirty hands are equal culprits. So, wash your hands. Theologically, there's a lot of debate about whether Holy Communion can make you sick, and I will leave that up to the theologians and you guys to discuss. I'm just kind of going through some of the scientific data that I've been able to find. So my recommendation is, if and when you have permission to offer Holy Communion to anyone, you should always wash and sterilize your hands beforehand, including any Eucharistic ministers, and the people receiving it should also wash their hands before they receive it. So that would just be my personal recommendation. When I was in Liberia, before we could even enter the church, everyone had to wash their hands in bleach water. So that was how strict they were taking it before you could even come to Mass. And so I think in this situation, I think it'd be reasonable to ask everyone to clean their hands as they're entering, if and when Mass is resumed. However, if you're celebrating by yourself and it's just for you, obviously that's a different situation. But if you're going to offer communion to somebody, I would recommend, and you can look at the logistics of this, but that you approach, that you breathe out, and then you try to step back to a 6 feet distance. I don't think if that's the only encounter you have with somebody, and that's the only close contact, you do not need a mask for that, unless they're just really coughing up a storm and you know that you can't make it there and back again before they're going to be coughing all over you. But I think that should be sufficient. But if you're concerned, wear a mask, and I think that's completely reasonable. So I would recommend in the hand rather than on the tongue, but that's really up to you guys to discuss. Either way, I think that you should clean your hands immediately after offering Holy Communion to somebody. Again, that's me. That's not anybody else. That's not any body of organization or anything like that. So, but take it for what it's worth. And I think if we do have this huge peak that is potential, hopefully will not happen, but it might be helpful to have hosts on hand for those that would need it, and to make sure that the person who's consecrating those is not sick, and is, if any concerns whatsoever, wear a mask. I don't know if you can place it in individual Ziploc bags. I don't know the logistics of that sacramentally, but one idea I had was to put it in a Ziploc bag as part of your emergency kit, so you're not putting a whole bunch together that you're handling as you're going potentially from one person's home to another person's home. I think that would be not a good idea. So what about the sacrament of reconciliation? So I, again, think that 6 feet away is sufficient. I think the way that it's set up right now is fine, where I think people are facing opposite directions 6 feet away. If you're concerned, you can wear a mask. I really don't think it would be necessary, but I think that if you're concerned, like, it's not inappropriate to do that. Just make sure you remove it properly. And I think if you're going to be within 6 feet of somebody, you should assume that that's probably going to be more than 10 minutes, potentially. And so you should at least have some sort of personal protective equipment. If you can do it more than 6 feet away, great. If someone is coughing, sneezing, if they're sick, ask them to wear a mask, even if they're more than 6 feet away, because you don't want them coughing up and down the hallway and that sort of thing. There is, the Vatican has released an apostolic penitentiary statement, and I don't know how to interpret that, but I think there's different interpretations of it, and so that would really, I think, be up to the bishop to decide to what degree that would apply here, and whether that comes into this at all. And I really have literally no idea. I just read it today. So what about the sacrament of the sick? So again, all of this is assuming that you're ministering outside of the hospital. I think hospital policies will continue to develop, and that is something that is there. But all of this is based on the assumption, hopefully false assumption, that there may be a huge need for clergy in the outside of the healthcare setting, and I think that is possible. If you are ever close to somebody who's sick, particularly with COVID, I think that you should be wearing personal protective equipment. Whatever you can find or use or have would be a good idea. And try to remain 6 feet away from people that are sick, as much as is reasonable, as much as you feel like is pastorally appropriate. I would treat family members that are in the household as if they are also sick, because you just don't know. They're on quarantine. If their family member is there on isolation, they're on quarantine. You just don't know yet if they're going to have symptoms. If you touch someone, I think you should wash your hands immediately before touching anything or anyone else, just because, again, the chance of you accidentally, even if you have all of your stuff on, like you can still just track things, and you just want to make sure that you're mindful of that. I'd be careful about, hugging people or whatever, just because it can dislodge your mask and your goggles. I don't know how often that would happen, but as you're ministering to people and comforting them, just be mindful of, that this can get moved around, and you want to make sure that it's in place. I know some people have said that they've been recommended to use a Q-tip for chrism oil, and you can place it in a bag afterwards. And I still think, even if you do that, probably a good idea to wash your hands, even if you never touch the person. One idea I had was you could use very small vials of chrism oil. You could dip the Q-tips in oil at home. I don't know if that's sacramentally possible, but those are just some ideas that I had about some ideas to make it so that you're not using the same vials and from home to home to home, or like trying to clean them all the time in between. Maybe that's something you can do, and you feel like that you would be comfortable making sure that it's cleaned really well. But again, you just want to make sure you're not like cross-contaminating would be the word that we would use. Sacrament of baptism, I would recommend, if you feel like it's appropriate, instructing the faithful on how to do this, just in case, there may not be a chance for a clergy member to get there. I don't know how often that would come into play. Again, we think about this a lot for newborns, and I think newborns are actually doing well so far. So, but it just be something to consider. But if you do offer baptism to somebody, particularly if they have COVID-19, I would recommend, again, mask and goggles. Think about splashing, just be mindful of that, and wash your hands afterwards. So these are some ideas I had for your emergency kit, so that if you're ever called on to go somewhere, that you have these available to you in a way that you're not kind of cross-contaminating with like your whole supply, so you could keep it kind of separate a little bit. If a person coughs in your face, what we do in healthcare is nothing. Like, or if they, if you get blood on you, if you're doing a procedure, or whatever, you finish what you're doing, as long as you can kind of see or whatever. And then when you leave, you take off the face shield and the mask and everything like that. So it's not an emergency. You don't need to do anything if you've got mask and goggles on. If you don't, and somebody just happens to like cough at you, and you're like, oh my goodness, I just got this huge, I could feel it, as it was landing on my face. I would recommend just go to a bathroom, grab a napkin or paper towel or something, and just try to wipe kind of the areas, kind of wipe it away from your eyes and nose and mouth. And then, wash your hands, and then try to wash your whole face. If soapy water is available, you don't want to get it in your eyes, but keep your eyes, nose, and eyes and mouth kind of closed or tight. Try to breathe out. That way you can kind of wash it away. And I would recommend you doing that probably sooner rather than later, and not waiting until you get home to shower, just because I think you have a greater chance of accidentally touching your face later on and tracking that around. And then, of course, wear a mask and goggles if that person is actually sick. What should you expect to see? So most cases are going to be mild. They're going to have the flu, bronchitis. Maybe they need a pastoral visit, but maybe you can do that by video or phone. I think people will be worried, and I think that they would really appreciate having their pastor minister to them, even if they just have a mild or moderate case. Even if they don't need to be in the hospital, I think that would be valuable, but I don't know that you necessarily need to risk yourself to be in that situation. That said, people can go downhill pretty quickly, particularly people that are high risk. So if it's someone that you think has a reasonable chance, then maybe they're going to be home for a couple days, and then you think, I don't know if they're going to do well with this once this really sets in. Maybe they've tested positive, and you're kind of waiting for things to sort of, we talked about it can take several weeks. Maybe that would be someone that you would want to do a pastoral visit with, and that would be the situation where you would go through all of this. Probably easier to do before they get very sick, when they can still, talk more easily, and if they want to have a sacrament of confession and all of that, like, I think that would be easier before they kind of go downhill. Plus, like we said, hospitals may have different policies for ministry within the hospital. So those might be people that you would prioritize for an in-person pastoral visit. Again, only if necessary, and you have to consider the risk that you're putting yourself at. Severe cases say that there are people that are sent home on palliative care. They may have profound difficulty breathing. They might have some severe coughing or chest pain or delirium. That should be something that you would expect to see as you're ministering to people who are on palliative care from this. And they may not be able to tolerate a mask, but you should definitely wear yours in that situation. If it's possible, they could cough away from you, but I still think you need to be very, very careful and how you go forward. And what should you do if you feel sick? So again, stay home if you feel sick. If you have difficulty breathing, kind of your typical thing, call 911 if you need to, like use your common sense. If you have mild symptoms, right now we really don't have a lot of testing available. So I think they've just now started drive-through at GraceMed. So there may be more testing options this next week. But ideally, stay home, get some rest. Same thing as you do for every other viral infection. Maybe vitamin C helps, maybe zinc helps, maybe vitamin D helps. I don't have strong evidence, but there's some evidence that it might. Cough and cold medications. They're kind of going back and forth about ibuprofen and naproxen. Probably avoid those for now, but the evidence is not very strong one way or the other. If you're getting worse, call your doctor. They can decide if you need to be tested, if you need to be admitted, or if you need to go to the emergency room. And then according to current guidelines, you need to stay home. You need to stay home for at least 3 days after your symptoms are fully resolved. If it's, and it has to be 7 days since the start of your symptoms. But I personally would recommend staying home a bit longer just because you might still be contagious. So just be mindful of that. So what happens if you're on quarantine? So I think this is a key point for clergy. If you are ministering to somebody that has COVID-19 positive in their home, you start your quarantine. And every time you see a new person that has COVID positive in their home, you start your quarantine over again. So you could potentially be on permanent quarantine. Ideally, when you're on quarantine, you're actually not going anywhere, right? You're not supposed to go to people's homes. You're not supposed to be interacting with people. I would say the only people that you could potentially interact with would be people that are COVID positive. But then again, you restart your quarantine every time you do that. You should not be around well people again. Don't be around well people if you're on quarantine, if you've been around somebody that has had COVID-19. So one of the things I thought was maybe assigning priests to this duty, but also recognizing like this could have if we really hit a peak, we could have it could be hard emotionally and physically on that person or those people. And you also need ministers that are not on quarantine to do all of the other things that you do. So I don't know how you all will work that out, but just to recognize if in the next couple of months we just have a huge number of these patients, they will need some pastoral support somehow. These are just some other considerations that I'll let you all read about, having some sign-up sheets for people to either that need help or that can offer help, whether that's video, whether that's providing supplies or food. Obviously there's a lot of people unemployed right now, and I think a lot of us just need to know how we can help people. We don't know how to connect the people that need help with the people that have resources. So those are just some considerations for you all. Here's some of my references. There's a couple of trackers there, obviously CDC and WHO, the Kansas Department of Health. And then I wrote a blog, just some tips for clergy and church members. It's not only for Catholics, so it has a bit of a broader audience. So you might see some of that reflected, but that was my thought. So my goal for all of this was just to help provide some information about how clergy can keep themselves safe and healthy and throughout this time. And I'm happy to answer any questions. On the first slide, it has my email address. So I'm very happy to take any questions you might have, or we can brainstorm together on ideas and then go from there. And hopefully none of this information will be particularly important, and we will get through this next season without too much of a bump in the road. But and I guess lastly, I just really appreciate all of you and your ministry. And I know the ministry is different right now than the way that you normally do it, but I know myself and all of us are very, very grateful for all of the online services and all of the different ways that we're able to continue to participate and live out our faith during Lent. So thank you for all you do, and email me with any questions, and I'll let you stop the recording. So thanks, Janet. Oh, any questions, Father Joe Tatro or Dr. Beard?
So, Dr. Gilbert, I was going to ask a question about cloth masks, because some of the priests will probably have parishioners or other people who volunteer to make masks for them. And I just wondered if you could answer the question about if they didn't have a filter in them, are there slits that they can remove and put in a new filter? Do they have like a rotating 3 of them and let one, dry for 3 days before they go and put it on again, and that sort of thing?
Yeah. I don't, so in terms of the data, all we have is, we have a couple of studies, one that shows that cloth masks are better than nothing and not as good as surgical masks. And the other study was from Vietnam, that showed that it actually made things worse, but it was because people were wearing the same masks over and over again and were only occasionally washing them. And they would get moist. And of course, Vietnam's was very humid, and they were never really, I don't think we're ever really drying out. So I think if you're going to wear a cloth mask, ideally have somebody sew in an area where you can put in across here a coffee filter or a vacuum bag, like I talked about, that you can just cut out literally and just stick in there. It's probably not all that comfortable, but I think that would be that would provide a better shield. They've shown that vacuum bags are equivalent to surgical masks, so that's why I bring up the vacuum bag so much. But coffee filters are probably good. If you just have a cloth mask and you don't have some sort of filter or anything else in it, probably, so I would recommend washing it in hot soapy water, and most importantly drying it, making sure it gets thoroughly dry, in hopefully a hot situation. If you don't have a dryer, maybe air dry things, I don't know, but you could iron it as well, and ironing it would get it to that hot temperature where it would be sterilized. And I think that would be fine. And then of course the other alternative would be leaving it out for 3 days, have it on a rotating schedule. I know some healthcare providers have cloth masks and they're rotating them every 7 days. I think there's so many people willing to sew masks right now that you could definitely have plenty. It's probably better to only wear a cloth mask for 4 hours because they get very wet with your breath. And once they get very moist, they're just not as effective. And so that would be the other thing to consider, would be having several masks during the day. Again, removing it properly and carefully, but not using it, for an entire day, which is hard to do anyways, but they do get very, very wet. And that adds a lot of problems to how well they work. So Linda Landau also has a sign-up sheet. There's lots of women that are interested in making these. I would say switch over to surgical masks if and when they become available. We know that companies are ramping up. At some point, we should have enough for the healthcare system. It might be another 3 or 4 weeks before that happens, but that might be the time when our peak hits anyways. So if somebody is really going to be in these situations, I just think that would probably be the best. I don't think we will have enough N95 disposable masks to go around anytime soon, because they're so much more complex to make. But obviously, if you have them, then and you prefer to use them, you can. They're really tight. They're very uncomfortable. They leave lines, on your face because they're supposed to be that tight. So they would be difficult for you to wear for a long period of time. And technically, they're supposed to be disposable. So I don't know how long they last, but that would be another option. Did I answer both of